Hello everybody, and welcome to our webinar tonight, Caring for COVID-19 Positive Patients in the Central Coast Community. My name's Jenny Pearson. I'm an Education Officer and I sit in the New England. We have several speakers for you tonight. We have Dr. Ellie Warren, who is a GP. We have Dr. Scott Forty, who's Director and District Director Anaesthesia and Pain Management at the LHD, and Dr. Christopher Trethewey, who's the Area Director of Emergency Services. We also have Erica Drew here, who's a Health Pathways Manager for the Central Coast. I'm just going to hand over to Ellie to get us started.
Thanks, Jenny. So most of you guys know me, I think, but I'm Dr. Ellie Warren. I'm the chair of the GP collaboration panel for the Central Coast, and also the co-chair of our Central Coast GP community of practice for COVID response. If you guys are interested, I wanted to mention that the COVID community of practice, because we can still take members. It's a great way to share information about COVID response locally. But before we get into the details, I'd really like to acknowledge the traditional owners of the land on which we're calling in from tonight, Darkinjung country, and pay my respects to elders past, present and emerging, and any Aboriginal or Torres Strait Islander people present with us tonight. And thanks for joining us. We're still waiting on our main presenters. Actually, here he is, the man of the moment, Scott Forty. We really wanted to gather everybody together to just present to you a model that has been put together in response to the increasing numbers of positive cases of COVID on the Central Coast. And Scott and his team at the hospital have been doing a phenomenal job of monitoring all patients in the community. And now we're just looking ahead to plan to get GPs involved to assist with the monitoring of patients who we know at home, and just improve some of those communication channels and work together on an evolving model. So we expect that this will be rolled out very soon, within the next few days, early next week. And then as things change, the model can change with it. And we were very, very keen to hear your feedback and your concerns. We've just been involved, a couple of the GPs, so Karen Douglas from Terrigal Practice, and who is the chair of the PHN Clinical Council, has been involved in talking about and getting this model up and running, as has Catherine Palmquist, who is the PHN Disaster Response GP Clinical Advisor. So PHN LHD been working together to make sure there's a GP voice in coordinating this program, and I think a lot of it is about going to be just jumping in and seeing how it goes. So I think, Erica, you've just got a few words to say about Health Pathways before we hand over to Scott. Thanks a lot.
Okay, can I just confirm that everyone can see my slides okay?
Yes, we can.
Great, thanks. Okay, so thanks everyone for joining us. So in the last few days, I think it was last Thursday, we sent out a survey to general practices in the Central Coast, seeking your feedback and input into the proposed model, which the LHD, local GPs and the PHN have developed quite quickly. So thank you very much for everyone's responses from the practices. We had 49 responses, and 25 practices indicated at this stage that they would opt into the model, which is great. And then after this webinar, we welcome any other practices that would opt in as well to support the LHD in caring for patients in their homes. I'll just quickly go over the information that's on Central Coast Health Pathways related to this topic. So if you haven't seen Health Pathways before. Sorry, I'm just seeing if I can scroll through. There we go. So here are the login details for Central Coast Health Pathways. It's a website for health professionals, so it's got a username and a password. And then we also have a companion website for patients in the general community, which is called Central Coast Patient Info, and anybody can access that. This slide is just covering about Health Pathways. Health Pathways is a way that local health district and PHN and local clinicians, including general practices, specialists, nursing, allied health, non-government organisations, can work together to articulate the local health system and improve the referral journey and the patient journey through the system. So in relation to tonight's talk, Dr. Jill Sass, one of our GP clinical editors on our team, has updated the pathway that was previously titled COVID Ongoing Assessment and Management, and now this will be known as the Shared Care in the Community pathway. I've just put those arrows there to indicate where it's located in the table of contents. So it's under the Assessment and Management section, and then Shared Care in the Community. And you can also just use the search function as well to find it. So that's been updated in line with the latest versions of the ACI guides and also the proposed model that we're talking about tonight. So that's a supporting resource that you can use after tonight's webinar if you're opting into the model. I also wanted to just mention a new pathway that was published last week as well. So that's the post-COVID-19 conditions. So as we're moving into this new phase of living with COVID and the cases are likely to increase, there may be the need for more longer-term support of patients who have had COVID. So that pathway has been localised for our region, and hopefully that will support you in supporting patients over the longer term if they've had the long COVID symptoms. And if you are supporting patients, you're welcome to share this website with them, Patient Info. It's got reputable information. We link to peak bodies and reputable sources that have been collated and curated by the GP clinical editors and our team. So it's reliable information that you can share with patients. And lastly, I just wanted to flag that you can contact us at any time. There's the way to find that on the website. Top right, contact the Health Pathways team, and on the top right of every page of Health Pathways is the send feedback button, and you can also just use the email address there to send us input, suggestions, information, updates. We welcome that. Thank you very much.
Thanks, Erica. So we'll hand over to you, Scott, if you're ready to go. And are you happy to do your slides yourself?
I would love to do my slides myself, but I can't find the button to present. So would you mind doing it for me? Oh, you made me a presenter. That's even better. That's why I was so confused. Catherine sent me a text saying, "You look like an idiot, Scott. What are you doing?" I was looking for the button that said present desktop. No, she didn't really say that. But, yeah. So show my screen, okay. That's good. You've got control. Now.
That's right.
Now behind this screen, you can't. What can you see there? Behind this screen.
I can just see you're connected to GoToWebinar on your screen.
I'm just gonna have to. How do I get down behind this screen to my? There we go. Okay. I can see it. No, if I hit the X, what happens if I hit that X? We all quit. We all gone. We say goodnight. That one.
It should be fine as long as you don't hit the X in the panel on the side in the where it's got your camera and your microphone.
Okay, well, I was brave and I did it.
So now I can see your emails.
There we go.
Yep, now I can see your slides.
Thank you very much. Apologies for that. I don't want a new slide. What am I doing? Anyway, it doesn't matter. I'll just present from there. Chris is going to be a little bit late. He just told me though that that you had a collaboration meeting last night in which that you have regularly with Chris and Fiona Wilkinson. Is that right?
Yeah, we did, Scott. Yeah.
Can I just ask, what do you discuss there? I imagine it was all COVID, was it?
It was a lot of COVID. Yeah, we went. We didn't actually have much COVID on the agenda, but their meeting went long, and we spoke about COVID for an hour with Chris, which was really good. Just to get his perspective on emergency department and how GPs can sort of it's all about communication channels really, and he'll speak about that tonight. We got an update from Kat as well, a public health director, about the number of cases. That's worth mentioning if people aren't aware as well how well we're going with vaccination rates on the Central Coast. We are up to 86% now, having received a first dose, and 58% double dosed. Kat actually quoted, and I will remember this quote forever, she said that unfortunately COVID is like a heat-seeking missile to socio-economic disadvantage, and so more cases in underprivileged populations like Aboriginal and Torres Strait Islander people, homelessness, mental health clients, and people with drug and alcohol conditions. So those sections of the population are also under-vaccinated. So we're playing catch up with Aboriginal community, and they're currently doing pretty well now. So 70% have received a first dose and 41% a double dosed. So that is phenomenal considering where we were 2 weeks ago even. So yeah, doing pretty well there. So that was a good thing to share with the GPs online tonight. But take it away there, Scott. Thanks.
No, thanks, Ellie. That's really important. Look, I'm Scott Forty, so I'm the District Clinical Director, but I've been on the coast. I was a resident here in 1987 when there were 9 interns at Gosford Hospital, and it was that little shack, and Wyong was a little, it didn't have theatres or hardly any wards. It had an ED and lots of issues, horses running down the street, multi-trauma, all sorts of stuff. And so we've seen a lot of change in the area. I know a lot of you, I'm sure. And some of my best colleagues, friends are GPs on the coast, and it's really good to engage with you all, and it would be good to use this as an opportunity to actually link better, for better ongoing collaboration. That sometimes these crises set themselves to do that, and I think we've got to take that opportunity. It's very. I've taken on the medical support role for the community as a leader in setting it up. I've taken on the medical support role for the SHA as clinically. I've got Elizabeth Rennicke, who's running the medical support officers for the community support team. And tonight I just wanted to tell you about the community support team and propose a way in which I think GPs could definitely help with what we need to do. The very first thing I'd like to make clear to everyone is that every district has a different model depending on what was either set up before or what's been set up for them. And that is critical to understanding what's happening. Assumptions are death in this situation. And for example, Prince Alfred and other parts of Sydney, they had really well set up hospital in the home, virtual care, medically run, well-staffed nursing facilities that they could turn over fairly easy to look after COVID, manage the 1,000 patients in their SHARs, various SHARs, the special hospital, health accommodation, hotels down in Sydney. That's not the same on the coast. We have, as you know, an APAC service that can hold a maximum of 25 to 30 patients. Now that includes all those patients on infusers for antibiotics or having twice daily antibiotics, and some of those patients with breast drains in as well. So it doesn't give us much room in our APAC model to look after patients with COVID who might need high level monitoring. And when we talk about monitoring too, there is a welfare check, how you're going, any symptoms, so on. And then in the model, which you've probably seen, we'll just go through it shortly, there's a twice daily check. Now, I'm not asking GPs ever to do a twice daily check. GPs are GPs. If I was asking a GP for a decision, it would be on using your medical and clinical acumen. What's your opinion of this patient? Do you think they're okay? Do you think they can stay at home? Do you think they should come in? So the BD thing is actually just something that's come from the model, BD checking. and it's not necessary, it's not possible most of the time. It's all well to write a plan. Half the time we can't contact people for days, and especially in those groups that you said before, Ellie, especially in patients with mental health issues, drug and alcohol issues, high dose methadone, patients who have, or Aboriginal people as well. They just won't answer the phone if it says no caller ID. So we know that we use our support services to contact those people to make sure they're okay in the community. But it's not, as written down in this plan, as easy as it may seem. Now, so every district has a different model. We have a very flexible ACI guide, which we really thank, and I've thanked the creator of the, I might go to the next slide. Oh, I can do that myself. Oh, hey. No, I can't. I'll try something. Changing, it's just a bit slow, I think.
Yep, just click one more time, I think, Scott.
Oh, it is, because I introduced that stupid blank slide, didn't I? Yeah. So we have a very flexible guide, and I thank the creator of this, which was basically Tracy Tay at the ACI. She usually works in Newcastle. She's been down with the ACI for quite some time, and she's been very good working at the ministry and putting out guides. Last year, in March 20, from March 20 to November, the LHDs and individuals in LHDs had to make up their own guidelines for all sorts of things, and it was chaos. Everyone was quoting we needed to use P3 masks because that's what the UK guys were doing. We were saying, sorry guys, we don't have P3, we've got P2, move on. It was classic. We had to come, we were ahead of the ACI, we were ahead of all the other government agencies. It was really quite chaotic. This year they've realised with the third wave that they can get ahead of that pack, and they've been really good at producing these guidelines. Now these guidelines aren't, they're evidence-based as much as they can be, but they are put out rapidly because they understand this is it is a crisis, it is a pandemic, and it's moving now to business as usual in a longer phase of a pandemic. So you'll see that some of the things I want to talk about here was how do you know where the truth lies in this? And I can lead you to that National COVID-19 Clinical Evidence Task Force for all things that do and do not work. They have wonderful flowcharts in there. If you're ever wondering about how you should treat a patient with COVID in the community, in hospital, if you're wondering if ivermectin is the way forward, or if the flu shot will help, or anything you can imagine, you go there and you'll see all the things that are not recommended to be used, all things that are recommended to be used. So the National COVID-19 Clinical Evidence Task Force is the overarching guide in how to treat COVID in Australia. The next part, which is really important, is the coronavirus disease, Cdna, national guidelines for public health units. In that is everything. It's updated regularly. Wherever it's updated, it highlights in yellow. But if you just type in Cdna national guidelines for public health units, COVID-19, or even some of those words, you'll have a hit on this. But this will tell you everything about the virus itself, the infectious period, the Delta variant, onset, likelihood of disease, the release from isolation criteria, what it means to be autoimmune, etc., etc. It's a really worthwhile document. It's 70 pages, but it's again the Bible that the public health rely on all the time. Regularly updated, worthwhile looking at, because in there is advice that as GPs you'll need to know as well. For example, on close contacts, because close contacts only get told you're a close contact. Here's the advice. See you in 14 days. And there's a lot of confusion about what a close contact is, especially when they're living with a case in the community. And we know of the 600 patients we've already had in our community here, that mixed messaging is really destructive to the families. And it's no one's fault, it's just that it's quite hard to keep up. For that reason, New South Wales Health have said, well, when we make a change, we're actually going to put it in a fact sheet. So if you go to New South Wales Health and download household contacts of COVID-19 or get COVID-19 fact sheets, you'll see all the fact sheets, and they're dated down the bottom as to the month that they came out. So that's the way you know they're current. So for example, not long ago, about 2 weeks ago, household contacts of COVID-19 rules changed, and had quite a significant change, because that meant that instead of if you were a close contact living with someone with COVID or a family with COVID, you had to isolate with the family with COVID, and if you didn't get COVID, then you have to isolate for 14 days from the last contact you had with someone who had COVID. So if you're a poor mum with 2 kids who had COVID, 2 kids go through 2 weeks, then you have to start all over again and do another 2 weeks. So now the really important change in this document is basically you have to isolate from the time that one of those, the case turned positive. And if you're isolating with a family that has both close contacts and the case, you isolate from the time when one of those other people turns positive if they do so, which is so much better for 14 days from then. So instead of having a 28-day isolation period for that poor mum, it might only be 18 days or something like that. Huge difference. Pretty wearing having locked down for 2 weeks, as we know. The other thing that we're in medical support to is the SHA, the Special Health Accommodation, and I'm sure you're all aware that it's the Ashwood Hotel in, it's no secret, it's guarded, it's got police, it's got security, it's got everything in West Gosford there near the Kentucky Fried Chicken. It's luckily being renovated because the smell was pretty enticing. They were all ordering Kentucky Fried Chicken when the smell was wafting across. But that is now full. There's 40 beds, 40 rooms there, and it's full. It's been full for some time, and there is a wait list to get in. It's very expensive and resource draining to set these up, but it's an absolutely critical part of the management of COVID in the community for patients who can't isolate safely at home, which are patients who don't have a home, but also many of the patients whom are serious drug offenders, just out from jail, people kick them out. You know, it's not the nicest side of life, and I can't imagine what it does to them if they're cooped up in a 3 metre by 4 metre room for 2 weeks. It's pretty hard. So they've tried to look after them pretty well, give them some outdoor space, let them smoke if they want to, all that sort of stuff. They're doing their best they can there. And there's a lady called Louise Weymouth who looks after that. I just take my hat off to her. She's been on call for 7 weeks, every day, 24/7, answering their calls. She's worn out. It's really hard, yakka. So we have a flexible guide, the ACI guide, which is caring for patients in the community. We have many opinions. That's why we use the National COVID Clinical Evidence Task Force and the fact sheets. Yeah. And the Corona and the Cdna guide, because otherwise opinions go wild. And in the hospital at the moment, they're going wild. We just have to revert them to the guidelines. So much better. Now, I just want to thank the GPs have already, and thank you to the PHN for reaching out and the collaboration, Karen Douglas and Ellie and the Catherine Palmquist who brought advice from Dubbo and what it's like out there. Thank you to everyone who's done all that, and particularly there's so much more to do, but what I wanted to do tonight, we'll just go to the next slide, sorry. What I wanted to do tonight is just also explain what happens when someone tests positive. What is the process when you rock up and have a swab up your nose and it goes to a lab and it tests positive? The first thing that happens is the public health unit is notified. It goes on their line list. And now the public health units are all, Kat Taylor was with you last night, she probably went over this anyway. The public health unit do an interview. Case contacts from that initial interview are then interviewed as well to go upstream and downstream trying to find out what was the source and who you might have spread it to. The cases are entered into the patient flow portal, which has a risk of hospitalisation score. Now the patient flow portal is purely it's Ministry of Health. We use it to get patients through EMR onto the community client list. They talk to each other, which is nice. Our community support team, of which is we're trying to build this up, but it is basically nursing doing the initial interview with medical support if they've got any questions. Then it's other clinicians, but some of them might be dental technicians or whatever they might be, doing the welfare checks. A lot of those have come from redeployed staff or casual pool. And then there's another group in there looking at the pre-release from isolation, trying to get that all ready. You can imagine with 30 to 40 patients a day coming into this, that means there's 30 to 40 patients going out. So you miss that for 2 days, you've got 100 people you've got to release from isolation. They get pretty cranky if they don't have the right paperwork and get out of their home. Oh, you would too, I'm sure. Now the risk assessment that's made, that's is on the ACI document is green, they're fine, orange, concerns, and red. And that's how we try to look at the monitoring. So green, for example, we would like to do a daily welfare check in with the family, make sure you're going okay. At some point, we're going to start to use a text service for that. Text us back, you know, are you okay? When we identify either medical risk factors, social risk factors, or any symptoms of concern, then that's when they go to orange. And that's when we might actually think about doing it twice daily. It might not be possible to do so, but at least we'd have a high level of assessment for that group. And red, they're the ones we're most worried about. We don't want many 2 reds in the community here. We're not set up that way. It's not a medically led model. It's a medically supported model, but the red are the ones we're quite concerned about. The other really important thing at the outset in this risk assessment is to identify patients who are suitable for sotrovimab, and we're in the middle where we've almost set up a clinic. Next week should be running. It'll be at Gosford Hospital site, but not within the facility. Obviously, you want to take people with COVID into the hospital site if you can avoid it, the facility. But it's going to be in Holden Street, in one of the buildings, just one of the little shacks, one of the old fibro shacks just next door to where we do the swabbing now. The intention there is to get patients who are early, who have certain risk factors. These people are at risk if they get COVID, and to give them this drug within 5 days of symptoms. And of all the treatments, it's probably the one with the best efficacy in treatment, and giving it early is the key. So obviously picking patients up early in the process is important, especially because we're planning to start with the clinic Monday, Wednesday, Friday at the moment, see how we go. Already we've had 4 patients. We've had 1 patient treated sotrovimab in the ED. We've got 1 on the ward perhaps tomorrow. We had 2 we could have treated today, but we just don't have the resources to do it. We were going to go into the community, into the home and do it. But APAC are full, absolutely over the flowing, of course. So I was going to, yeah, anyway. So we're getting to that. Now, in the community support team, we do have that as our prime team with a leader, APAC. We do have good liaison with mental health, drug and alcohol, Aboriginal support. Drug and alcohol have offered their at-home detox service, and they've been really good at that. You probably are aware that Marulamalii, whatever it is, up at Wyong was closed down due to COVID exposure, so they had to redesign their whole workforce, and they're doing what they used to do before, which was detox in the home. We've got great support from our Aboriginal support workers, which is fantastic, led by Steve and Cindy. And the support medical officers are brilliant. They're just doing this voluntarily. So Elizabeth Reneke has got 10 specialists, all to just do voluntary shifts over weekends, 8 a.m. in the morning till 8 p.m. at night. And after that, our ED is our backdrop. So the key to this whole thing working, keeping people alive, is ED, because if we've got concerns, we have to say, we're going to ring you an ambulance, you need to go to ED. And those concerns, you can't leave the trigger too low. Like, you can't wait till their saturation's at 89%. You have to do it when they're, well one day, 98% one day, 94% the next day, and struggling to breathe or new chest pain. It's not an easy task. There is no, if I was to say what is the best way to track patients for COVID in the community to make sure they're not going to get sick, there is no best way. You can look up the literature everywhere. All that is recommended is to keep analysing yesterday's to today's results, yesterday's to today's symptoms, and looking for change. And if change is going downhill, then we have to pull the trigger. We don't really have that option of doing a virtual care consult with physicians. We can do that. It's one of those areas we probably ask the GPs to help. Every patient that's registered on our system, we endeavour to get them an oximeter, also a thermometer, and we try and close the loop on that pretty quickly, because we know that without an oximeter, you're hopeless in this. It's impossible. So that's key. So processes, I'm just going to go through to the end and then leave questions, if that's okay. If you haven't seen this document, it's a great little document. We all use it. I'm not going to show you it all, but that's basically our stratification to low risk, high risk, very high risk. We don't want very high risk in the community. But that's what we're trying to do. We're trying to stratify patients into these groups based on their medical risk factors and their symptoms. So one of the proposals, well, this is what we're doing. We've got CCST, the community support team is triage, and then patients will go into the community support team for welfare checks or APAC or mental health, drug and alcohol, Aboriginal support services, so they can do the checks. If they've got any concerns, they escalate it through back to the CCST and up through the support medical officers if they have concerns on the COVID aspects of their care. It's much better for them to be looking after the methadone withdrawal or the opium withdrawal or the ice withdrawal. But as
We've just lost you there, Scott.
I might just jump back in while we're waiting for Scott. Firstly, to just mention that we do have the question panel in the chat box there for people to be writing questions as you think of them, and we'll try and get to those after Scott's presentation. So a lot of the questions submitted before tonight's talk involve questions about billing and telehealth services. So I can just mention briefly that the GPs will be able to bill telehealth for consulting patients at home. Hi there, Scott. I'm just mentioning a couple of things about the questions before we get back to you. Telehealth will be able to use. So in other areas across Sydney and New South Wales, they have a hospital in the home model where the LHD have patients admitted essentially under their care, and GPs aren't able to bill telehealth. But in this region, in Central Coast, we will be able to bill telehealth for our care of patients in the community, which is really important for you guys to know that we will be able to be paid. So we can expand on that a bit later, but thanks, Scott. And I will mention as well, we do have Chris Trithui online too, so he'll jump in after you, Scott, to just mention a few of the things he raised with us at the GP panel last night. Thanks.
Thanks, Ellie. Yeah, I just dropped out for a second. Chris can correct all my lies about the emergency department. No, the emergency department, as I was saying, is our backdrop. We can't do this without that, and freeing up the emergency department to flow is our key, and it's tough at the moment. I'm just going to show you now. There's two proposals that I'd like the GPs to consider. The GPs could actually assess some of the patients, especially families and so on, known to them, and report back daily to the CCST to close the loop. It's not that we don't trust you, it's that we can't afford to leave people not, oh, sorry, my printer's just going off. We can't afford to not make sure that everyone has been checked in on. It's not that we don't trust you at all, of course we do. But that option is a bit tricky because it does involve handover of care and hand back and daily check-ins. And there are all sorts of problems around time of day, you know, from 4 o'clock to 8 o'clock at night, weekends and so on. The one I'd really like you to consider is what we're doing now actually. GPs can be asked for their advice on patients and families known to them as it's currently happening. So for example, if we're just not sure, and if we know that this family is known to a general practice, we could contact the GP and say, would you mind just assessing the family? We're just not quite sure if this is right from where we are. We've done that already. It's been really invaluable. We've had advice to say, no, they're fine. They're often like that. Or, you know, someone might be a bit drowsy or whatever it might be. And I think that's the way that I'd like to propose that we go forward at the moment. It might change in the next 2 weeks or 3 weeks or whatever, but that's what I'd like to propose. Now I want to move forward. So this is proposal 1 where we actually sit in and GPs sit with those other groups like APAC, mental health, drug and alcohol, just having patients that are suitable to go to for GPs. And by suitable obviously means they're already in your practice. And option two is this one where the support medical officers, it's like a consult, clinician to clinician, senior doctor to doctor consult to ask for an opinion on something we're just not quite sure of. I think I'm going to stop there. Yeah. Happy to take questions. But Chris, do you want to add? Did you have some questions for Chris, Ellie, or did you just want him to keep talking from where he was talking last night?
Hi, Scott. Yeah, Chris, if you're happy to jump online and just give us a bit of an update from your perspective, I think it's really important that the GPs know what's been going on already. And Scott, thanks for describing what happens with the community support team and the expectations on GPs. I think essentially it sounds like from our discussions with you guys this week that what you would be asking GPs to do would be to look after our own patients who are low risk in conjunction with your team. So it wouldn't be a handover. It would be we become part of the team who are assisting you, but we're not taking over care completely. So the medico-legal responsibility does not sit with the GPs, and it still sits with LHD, but it will also be a Monday to Friday type role. So you're not asking GPs to provide Saturday and Sunday care and all through the night care. Is that correct, Scott?
Actually, I don't even, that was model one. I think it's to start with, just because we want to keep control, tight control, we'd just be asking for your help for an opinion on a family or an individual that already sits with a GP. Rather than you looking after them Monday to Friday, it might be Thursday is coming, it's 2 o'clock in the afternoon, we're just really not sure about a patient. We look up, they have a general practitioner. Can we ring them to say we would just like your opinion? Are they often like this, or is this something you're concerned about if you have a chat to them? That's where I could find real value, because you know your patients so well, you know them. We would love that as an option. It's what we're doing anyway, informally. So I'm really not sure how many of the GPs would be happy to do that for us. I'm sure you all would. Whereas the other one,
I think so,
it's going to be a lot more difficult to set up the other way.
I think that less formal approach suits everybody to start with, at least, and we'll just roll with it and see how it goes. But what's really important is that we have contact numbers and ways to escalate things really quickly if we need to access this support medical officers and your team to really see if this person needs to go into hospital. So could you describe that a little bit to us? What would happen if we were concerned about a patient? What would the GP do?
Well, so if you were that concerned and it was an ambulance call, it's a 000 call. It's 000, call the ambulance, call the ED, tell both that there's a COVID patient coming and tell them why. But if it's one of the concerns, which is just, I'm just not quite sure here, it's back to the support medical officer, the one who's consulted you originally. So let's have a discussion about it. What did you find? Yeah, okay, that's good. We'll take it from there. Now, all escalation, if you're worried about food or nappies or whatever, that all goes back to the community support team. If you're worried about drug and alcohol issues, back to the community support team, only because they're really well set. I mean, you could probably do it yourselves, but they're really well set up at the moment to do this. That's what I'd be thinking. Now, the ED is, obviously, if it's front or obvious, go to ED. But what we don't want to do is flood the ED with everything, because then they can't do their job as well. Now, Chris Chathuri has been absolutely outstanding in inventive ways of treating patients or reviewing patients with COVID, like in cars and in funny spots and all over the place. But that's the thing, if he's not there, others aren't quite as inventive sometimes, and the whole place comes to a standstill. So it's hard. We don't want to undercall, but we don't want to overcall either. So we're getting very used to it. It might take a while to start up. So I'd suggest we do option 2 to start with until we feel a bit more comfortable with stuff. You guys are going to be so busy post-COVID anyway. I really think, you'll have a lot of post-COVID issues to deal with.
And some of the concerns from the GPs have certainly been coming in about capacity, that we're already overstretched, we're overworked, just trying to get everybody vaccinated, and don't necessarily have capacity to take on extra load with this. And also some concerns about our lack of skills so far in managing COVID patients. But I think as we switch from this emergency response to business as usual, we're potentially coming up with the model for months and years ahead. So people are going to get the hang of it over time.
Well, they will, but it's also just general medicine. You know what I mean? It's the stuff you do day in and day out. I mean, patients still have problems that aren't COVID related. We've just, we've got a lady with a, septic arthritis who's also got COVID and will fall over, break their leg. That sort of thing's going to happen as well. So yeah, you probably have to be forewarned for that reason alone too. But no, we're not going to. Sorry, go on.
I was just wondering if that's a good time for Chris to jump on. We've only got about 15, 20 minutes left, so please make sure you send in questions, guys, on in GP land. We want to make sure we use the experts while they're on the panel, and you can all follow up with PHN with questions later on, and we can hand them over to Chris and Scott if needed after the show. But let's see if we can cover most of it tonight.
Ellie, I know Chris was having some trouble with his audio. Are you there now, Chris?
I'm hoping I am. Can you hear me?
Yes, we can hear you.
Oh, great. Sorry, I haven't got a video, but I've got a face for radio. Anyway, it's worse than Scott 40, so that'll do you a favour. So really, I guess, Ellie, we're just talking last night about the experience in ED, and I think we're getting better at looking at what COVID looks like. I guess the key points that we raised last night, which are worth raising, just echoing what Scott said, that there's sort of two contexts for COVID. There's COVID where it's the driver of illness, and that really does look like a viral thing or a really nasty gastro thing, and the dehydration that we're seeing with patients who have had persistent diarrhea is actually much more significant than a bit of ORS and ondansetron. Or now, as the prevalence has climbed, we're starting to see people who've got separate problems, and COVID is a passenger. So we've seen people that have had motor vehicle crash who are COVID positive, and we're just working through that. The ACI guidelines that Scott's talked about are really helpful as a reference, and regardless of how this proceeds, as the ED is still providing a lot of the backup for the deteriorating group, we would just encourage you to feel confident to ring us on the 95300 number if you are involved in care and you need to send someone in. That's what we're doing with APAC, or call an ambulance, and the ambulance through the central coordination. There's a pretty robust system now where EDs are notified when you're sending someone in that is COVID positive as well. I'm really happy just to answer your questions more than anything else.
And I might just mention, sorry,
thanks, Chris. Yeah. We do have some questions from the audience. Sorry about that, Catherine.
Can you see those, Ellie, or do you want to?
I can now. Yeah, thanks. Oh, technical issues, yep. Thanks, everyone. We do have a question for Scott about how many COVID positive patients you are currently monitoring, and will this model get overwhelmed as case numbers increase?
Yeah, great question, isn't it? So we know there's been over 600 already, but there's about 400, 420, 430, that sort of thing that we're currently monitoring. I'm sure you've seen each day there's about 30 to 40 people added to that. And Kat Taylor probably told you that she is quite concerned about some of the groups, Canton Beach and various other places where there's been lots of exposure in the community. It's not been hemmed in, if you like. They haven't been isolating these people for many, many days. So she's quite surprised it stayed around that 30 to 40 mark. Now, if it scales up higher than that, what do? We need to scale up appropriately. There are things that what we are, as I think Chris, or you alluded to, Ellie, we are trying to change this from an incident control type thing, like a bushfire, to make it business as usual. And that has a lot of impacts if we can do that, because then we can get staff on contracts. We can get not just a casual pool of staff. we can try and work up and get better arrangements. What we are doing is trying to turn that 500 people in the community or whatever it is into one big ward. In fact, it's the size of a hospital, and it needs a lot of the resourcing to do that as well. It needs a lot of support, a lot of organisation, a lot of checks and balances, a lot of close the loop, and we're getting to that. We're getting to that as rapidly as we can. But I think we'll be okay as long as we can keep on. The problem is resources are going from our district to help West Sydney, to help Western New South Wales, to help everywhere else, to help the public health unit, to help everywhere else to do the same thing. That's been our problem. If this comes catastrophic, we'll just have to say to the GPs, we really need your help now. You know, please, we'll be advertising for nurses for people outside. We already are. You may be aware it's quite a slow process with onboarding people into the public system. It's a lot quicker than it was, but I'm sure if we hit to that real disaster level, it would get even quicker. My suspicion is it's not going to, though, for exactly the reason you said before, Ellie, in that we've got 86% for those vaccinated, and that's the. I mean, if you listen to the Doherty Institute modelling versus the Benetti or whatever the other one is, you want the scare campaign modelling versus the sensible modelling. Quite clearly, the reason this is going away in the community is because of vaccination, not because of anything else. So I reckon we'll be pretty comfortable to manage this as an outbreak. I think the peak numbers are probably still to come, and probably will be in October. But as to if it goes to 100 a day, I don't think that will happen. Could be wrong.
Yeah, and I guess that's the importance of making sure that we continue to evolve and adapt the model, isn't it, according to the need. A lot of the questions coming through, Scott, are about communication back and forth and how are we going to receive notification about these patients? Is it by phone or fax or email? How do we communicate back to LHD? Are you planning to send out discharge summaries or similar when you discharge patients from the service? And do you want to mention just quickly that that's a separate protocol, isn't it? The discharge, releasing somebody from isolation.
Yeah, oh, that's right. Well, that's right. So there's numerous things we have to produce when we discharge a patient from COVID when they're released from isolation. Close contacts, this is not for them. This is for cases, but they do need a clearance letter. They do need a medical certificate or a certificate. It can be done by a nurse, but it must be a certificate to say they are off work for this period of time. We do need communication to the GP when they onboard and when they go. We did need before a vaccine exemption for 6 months, which is a horribly pathetic form at the moment, but that's going to go because it's also included in their clearance letter. And the clearance letter basically says that they don't need to get vaccinated for 6 months, and they're to be treated as basically immune from COVID, is what it says. So there are those things. Now, we've had this issue, haven't we? There are two things. One is, how do we communicate? I've done some research back here, and Brendan, I'm pretty sure, was saying we can't use emails, but from our point here, we can use secure emails such as @health emails for communication. So we were thinking of setting up the @community support team health email for communication. The other thing that's there is via the Health eNet system, which is our systems server, which your systems pull off, the Argus and the Health Lab and whatever the other ones were, the same way as you would get your pathology from the hospital and your discharge letters now. Now, apparently, I've been told that this is functioning, but every GP we've spoken to says it's not functioning, so I think we've still got some work to do there. But we will have within our group the top level, Jerry is his name, top level guy for all that sort of EMR communication stuff with GPs very shortly within our group. So we'll get him onto that quick smart. But emails, secure emails is appropriate and is what I've been told, and reliably so, I think, by Jerry actually, and also the electronic communication. I did actually produce
PHN is I think PHN is working behind the scenes to set up the secure messaging, and there'll be more information coming out about that, how GPs and LHD can communicate well. There are lots of questions coming through now, so thanks guys for sending all of these in. We might not get to them all tonight, but we'll do our very best. A lot of them are in the same theme. Just quickly, could you comment, Scott, on the management of COVID in aged care facilities and how would this model suit them?
Do you know what? I've been so busy doing everything else that I've left that to other people. There's a whole model that's come out from the ACI called Management of Facility Outbreak in an Aged Care Facility, and I'd lead people to look at that. But honestly, Chris would probably know that better than me. I've just been so busy doing everything else. I've got to leave something from people.
Ellie and Scott, I can probably help a little bit there with John's question. So we have had a few outbreaks on the coast. We've asked all of the facilities to talk to the GPs who come there, and I think that's happening. So that you'll be asked to either provide telehealth support. There is a GP with most of the facilities who's the sort of key contact person. I don't know if that answers all of the question, but so far, she says, hanging on to the desk, because of the high vaccination rates at the moment, these are not, it seems to be going okay.
Yeah, that's great. And perhaps while we've got you, Catherine, as well, some people are asking if they've initially indicated that no, they're not willing to be involved as a practice, but after tonight's discussion, they are willing to give it a go. Who do they contact? How do we get this started? And how does it look like? How is this going to start?
Yeah, so I think the question there is from James, and James, if you would email back to Erica or Brendan through the primary care improvement team and the health pathways team, we'll be able to get that sorted. So I think what we need is an up-to-date contact, which we've got in our systems. So we just want to check with you, and then we'd be able to share that with the community support team to say, yep, these are the GPs who are willing and able and to manage this for their own patients. And then, yeah, that's probably about all we need to do. And we'll get this up and happening pretty quickly, I think, Ellie. There's a few things to sort out. There's some forms, so the electronic messaging and is consistent. We're just following up on some of the billing questions, etc. But yeah, it should be not too difficult now. So if you did say no, that's okay, because I think what we were asking before looks a little bit different to this. So yeah, just drop us an email and we'll add you back to the list.
Yeah, I guess that's a good segue to the telehealth questions, and there's a good question there from a couple of good questions there from Diana Treese. Thanks, Diana, about will GPs be expected to do home visits in this situation? And I think the answer to that is no, it would be all telehealth. In terms of billing telehealth, you would use the GP item numbers. If you do have access to the chronic disease item numbers by telehealth, you can have your practice nurse do those assessments. I guess, unfortunately, for some of these patients at home, they will have used up all their 5 chronic disease item numbers already, the 10997s. So I think we've sort of left it up to each practice as to how they want to manage this. In reality, Scott, are you thinking that it might be 1 or 2 patients per practice to begin with per week? It's not going to be enormous numbers, is it?
Well, initially it would only be a temporary thing. We ask you for a review, like as one of the doctor to doctor, please review, and then just as soon as you can get back to us, give us that. So it wouldn't even be that. If we went on further forward, yeah, probably something like as you just pointed out then. But you'd also, I mean, at the moment we don't. I think the most value for the GPs would be to use their medical decision-making skills and their eyes on the patients we're a little bit concerned about at the senior medical officer level. I really do, Ella. That's what you need. You guys are doctors. Perhaps the nurses could do the checks, you know, just to ring. If that's where we went, and you know, I saw a bit of discussion about nurses doing the checks. That's fine as well. But that is a bit harder to fund and so on. I understand that. But yeah, complex, doable.
And I think
oh, go, Catherine.
no, it is it is a bit complicated, but I guess these are the things, and Taya's got some questions here about, what does the model look like going forward after we get over this hump? And I think this is when we can, have some conversations about exactly how we do that, manage that, and, if additional funding is needed, etc., we can ask, I guess. Sorry, Erica, go.
Yeah, thanks. I just wanted to add in that the practice support team have developed a telehealth guide, which we've included in the handouts tonight, and you can always contact us for copies of that as well. And the phone numbers for some of the teams that Scott mentioned are included in the updated pathway, and we'll provide more information as we receive it.
You're a whiz with those things, Erica. Incredible.
Scott, there's a good question here from Stephen Kenny just on what early treatment we're offering as adjunctive therapy. Did you want to talk a bit about the sotrovimab clinic idea?
Oh, absolutely. So from next week, we'll have sotrovimab clinic up and running. It's been given once in the emergency department. It may be given tomorrow. We were going to give it to 2 patients today. As I said, we just couldn't get to them. Sotrovimab is the only thing really that's going to make a difference before they get sick, but you have to give it at the time where the spike protein can stop entering the cells. So that's why it's got to be given early in the course of their symptomatic disease. So it's within the first 5 days of symptoms. So if you find out, and these can slip through, but if you find out you've got a patient in your care who meets the other medical risk factors, which are, pretty obvious things, it's like over the age of 55 or over the age of 35 if they're Aboriginal, and kidney disease, heart disease, lung disease, asthma, diabetes, it's pretty obvious, immunosuppressed. Then if you get to them early enough, sotrovimab has a really good chance of turning them around, as in making them not get sick enough to come into hospital within the first 29 days of their illness. So yes, we're setting that up on Monday or next week as a clinic idea. But it's not simple because obviously transport's an issue. We need a bus. We need a bus driver. Christopher needs a bus and a bus driver to drive patients who've come in COVID positive somehow or get tested and turn out COVID positive. How do you get them home? You can't ring an Uber. So, and they often can't get home, so we need a bus. That's huge. If anyone wants to drive a bus, we'll take you off it. Yes, and that is the only thing that's really been shown to make any difference. I mean, we are sending out in our brochure the same guidance as ED are with their brochure about if you have COVID, perhaps thinking about some exercises you can do at home rather than lying around all day watching television on your back. Try lying around all day watching television on your front. But as we know, the best thing you can do for your lungs is get up and walk around. But if you are lying down, try lying on your front as well. So that's another reasonably useful thing to practice, get used to.
Certainly there are a couple of last-minute questions from GPs. I'm sorry we haven't been able to cover everybody's questions, but Catherine Palmquist makes a good point.
If you want though, we can do this again in 2 or 3 weeks' time.
Yeah, I think that might be a good idea. Yep. Yeah. Kath Palmquist makes a really good point, just to remind people that once our patients are cleared of COVID, they can be then seen face to face, and they'll need a good GP physical review after that. I don't think we've got time to go into what longevity is being planned for, but that's an important question as well. The other questions relate to what's going to happen with people who are positive who do not have a GP. That's a fairly large group of patients that you guys are looking after with your community support team. And at the moment, we're not asking GPs to be involved in other people's patients or patients without a GP, are we? Could you clarify that?
Oh, definitely not, no. I mean, a lot of these patients don't have a GP because they don't want a GP, or they go to a medical centre. It's different, isn't it? There are people who certainly want to go to see the same person all the time. I think that's a great relationship to have, but there are other people who don't. It's between 30 to 40% we think who don't have a GP.
Yeah, it's interesting. Taya, I'm going to finish with your question tonight. It's just 1 minute after 8 o'clock. Thanks everybody for joining us. So Taya, and fair enough too. It's I think we're just creating this model as we go. She says, I'm not clear what exactly is being asked of us now. Scott, could you just clarify in a nutshell, what are we getting GPs to do for you?
To be absolutely clear, if the senior medical support officer, the COVID medical support officer, which is either myself, Elizabeth Reneke, other members of PD specialists, they're all specialists, Dennis Crimmins, etc., has a concern about a patient, then we'd like the ability to ring the GP to say, would you mind having a look in on this family, this individual? I'm just not sure if this is right. I'm not sure if it's right for them. You know how there's that thing which is this normal for them? If you've known them for a long time, you go, yeah, they often talk like that or have a droop or whatever it is. But for us, sometimes that can be a bit difficult, and it just can be a lot clearer if we've got the GPs on board. That is what we're asking for you to do at the moment, and nothing else until we all get together and decide other things later on.
And all these patients have regular GP needs, don't they? They need contraception, they need scripts for antihypertensive, they need other things going on. So really what we're talking about, I guess, is just getting GPs into the loop, getting GPs involved, and we haven't been until now.
Oh my God, that's so true. I mean, some of them might be pregnant or exactly. We've been writing GP prescriptions for lots of people in the shower and various other things, but you know, at times it might be easier if you guys do them because you have those relationships, you know exactly what drugs they're on, and you know the pharmacies they go to. Yeah.
And Chris Trithui, you've got such a wealth of knowledge. We haven't tapped into your brain too much tonight, but Chris, did you have any final thoughts and anything else to add to for the GPs tonight?
Not really, Ellie. That's very kind of you to say. A wealth of knowledge, it's probably not, but I look forward to catching up again. I agree that these models are evolving, and I think I'd just say to the GPs, as we have had to do in ED and critical care, there is a spool up. You know, when you're trying to anticipate what happens, we are evolving and changing and rolling with that, and all of us are fairly tired and change averse, and we need to continue to work together to see how it goes. So I look forward to meeting again and talking in the future.
Thanks so much. Jenny, did you want to finish up for us, or Catherine Turner, any parting words?
I'd just like to say thank you very much to the presenters, and Ellie, thank you very much for facilitating the questions. It's just works so beautifully when we have a GP to do that. There will be a question, an evaluation that will pop up at the end of this webinar. It will only take you less than a minute to fill in, so we would love you to do that. Yes, as requested by Scott and Ellie, we might try and look at doing another one in a few weeks' time. Catherine, did you want to say anything before we finish up?
Oh no, just that I think I was just sent Scott a message. I think we've put some people's minds at ease, but we're at probably the start of we're nowhere near the end of this particular process. So yeah, if we meet again in a few weeks and we continue to work through this, and you know, if anybody needs assistance with any of this, reach out to the PHN, to any of the people on the panel. And yeah, and thanks to Ellie and Scott and Chris for their time. I thought that was really helpful, and I've learned a lot as always. So thank you.
Thanks,
Cheers,
everybody.
guys. Thank you.
Stay safe.
Yeah, you too. Good night.
Good night. I don't know how to hang up.